There are no conflicts of interest among the speakers, and there's no commercial interest represented here. At the end, we'll have an evaluation link sent to put in the chat so that you can get credit for this evening. Without further ado, let me introduce our president, Dr. Omer Deen, president of the LA County Medical Association, and he will be introducing our speaker today.
Thank you, Dr. Flores. Welcome, everyone. It's a pleasure to have you here with us. We have a real treat today. Dr. Elaine Batchlor is here, and I'd be happy to introduce her. I have some notes here, so I'm going to have to go off video here briefly. So Elaine Batchlor is Chief Executive Officer of MLK Community Healthcare. It's a health system that includes state-of-the-art private safety net hospital, the MLK Community Medical Group, community, as well as population health programs and fundraising foundation. Dr. Batchlor's innovative work to increase access to quality healthcare for underserved populations has been recognized on a national level, earning her membership in the prestigious National Academy of Medicine, an academy committed to advancing science and health equity. In 2019, she was also recognized as an Irvine Foundation California leader. Before assuming leadership of MLK Community Healthcare, Dr. Batchlor served as Chief Medical Officer of LA Care Health Plan, the nation's largest public health plan providing care for a safety net population. She has also served as Vice President at the California Healthcare Foundation, where she developed and oversaw research, policy analysis, and programs aimed at improving healthcare financing, as well as delivery in California. Early in her career, Dr. Batchlor served as Medical Director for the Los Angeles County Office of Managed Care and as a Chief Medical Officer for Prudential Healthcare. As a thought leader in the healthcare industry, Dr. Batchlor is a member of the ZTEMA Project, a group of national health experts focused on improving policy and business decisions in the U.S. healthcare system. She is a member of the board of directors of the California Hospital Association and the Hospital Association of Southern California, as well as the Integrated Healthcare Association and Insured as well as Uninsured Project. She served on the Health Affairs Editorial Board and is an advisory board member for the UCLA Fielding School of Public Health and the Hospital Quality Institute, among others. So, a Harvard alumna, Dr. Batchlor serves the university as an interviewer for the Los Angeles area. She holds a Bachelor of Arts degree from Harvard University, a Master's of Public Health from the University of California, Los Angeles, and a Doctorate of Medicine from Case Western Reserve. By the way, Dr. Batchlor, I trained at Cleveland Clinic just down the street, so that's fantastic. Mm-hmm. With that, I will turn it over to you. Thank you so much for being here to everyone. And Dr. Batchlor, it's a pleasure to have you with us. I'll turn it over to you now.
Okay, thank you, Dr. Deen. Thank you for that lovely introduction. And since I'm talking to a group of doctors, I will assure you all that I am still a physician. I am boarded in both internal medicine and rheumatology, although I will confess that it's been a while since I have actually taken care of a patient. So I am someone who has deep respect and admiration for the work that you do every day in taking care of patients. My career is really focused more now on the care of populations and communities. And what I am going to talk about in the brief time that we're going to spend today is how I look at health equity through a lens of a hospital and a healthcare provider organization, especially in the wake of the COVID pandemic, and how we are trying to advance health equity at my health system, and a little bit about the policy barriers and the need for policy change. And Hector, I'm happy to take questions anytime you think questions would be appropriate, but I'll try to run through the slides quickly so that we can move into more of a discussion. Sound good? Okay, so if the slides could be put up on the screen, I would appreciate that. Thank you very much. So I'm going to start just by telling you a little bit about who we are at MLK Community Healthcare next. We are a healthcare system that includes a hospital, MLK Community Hospital, and a medical group, MLK Community Medical Group, that is a medical foundation model medical group with multiple practice sites now. Next slide. Our community that we serve is the community of South Los Angeles. It's a community of over 1 million people. It is a highly underserved area. It is predominantly brown and Black people who live in South LA. It has significant health disparities, as you can see on the screen. And we also suffer from a lack of healthcare providers and healthcare infrastructure, among other social determinants of health that you see listed there as well. Next slide. So in addition to lacking physicians, the 1,300 to 1,400 physicians that you saw on the other slide, which includes both primary care and specialists, we also are the area in Los Angeles County that has the lowest number of hospital beds per 100,000 people. Next slide. Our payer mix is primarily Medicaid and uninsured. So once CalAIM is fully implemented, about 70% of our population will be covered through the Medicaid program, with about 19% covered by Medicare and a very thin sliver of commercial insurance. Next. This is a table that we put together using data from the Federal Health and Human Services Department that was publicly shared during the COVID pandemic. This data shows the number of COVID patients in every hospital across the country compared to the number of licensed beds. And we regularly looked up this data and compared ourselves to hospitals within about a 10 to 15 mile radius of our hospital. And I was actually quite surprised initially to learn that we had a larger burden of COVID patients than large tertiary medical centers, that we even had more COVID patients in absolute numbers than hospitals like Reagan UCLA Medical Center. The reason for that is multifactorial, but it's the things that we've grown accustomed to talking about. The fact that our community is low income, it's mostly brown and Black people, people who have occupational exposure as essential workers, crowded housing and less ability to quarantine and isolate after being exposed, a significant burden of chronic illness, and worse access to testing and to healthcare. And all of that, kind of created the perfect storm for this COVID pandemic, and means that our community was significantly impacted by COVID. Another marker of the impact COVID had at our hospital was a report that I saw recently produced by the Loan Institute that shows the highest impact hospitals by city across the country. And again, MLK Community Hospital was listed as the highest impacted hospital in Los Angeles City, even though we're not exactly in the city. So I think what all of this adds up to is evidence that South LA is a model of a community with significant healthcare disparities. Next slide. So what is my definition of health equity? Well, it's listed right here. Health equity is when we all have a fair opportunity to attain our full health potential, and we are not prevented from achieving our full health potential by social disadvantages. And those social disadvantages could be race, ethnicity, language, gender, sexual orientation, geography, whatever type of social determinant we might be talking about. Next. And so some might say, why do I care so much about health equity? Well, it's actually pretty simple. I care about social justice a lot. I grew up during the civil rights movement and the Black Power movement with parents who were active in the civil rights movement. I actually went to the March on Washington when I was a child. I grew up in the Washington, D.C. area, and I don't want to live in an unjust society. And I believe that health equity is a matter of social justice. I'm a doctor, and as a doctor, I want all of our communities and every individual to be as healthy as possible. And I don't want there to be impediments based on social determinants. And then finally, I've spent most of my career working to improve access and quality of healthcare for disadvantaged communities. And I continue to do that. Next slide. So I thought I would talk a little bit about what health inequity looks like from the perspective of a hospital located in a significantly underserved community. Because I think as a hospital, we have a fairly unique perspective and have an interesting view of what's happening in the community. So from our vantage point, it looks like high use of emergency department for low acuity conditions. We have an emergency department at our hospital that was built to support about 45,000 visits a year maximum. We do over 100,000 ED visits every year. And a significant percentage of those visits are for low acuity conditions that in a community that had better access to primary care, urgent care, care in the community would be happening outside of an emergency department. And I'm careful to say that this is not because our patients are ignorant and stupid. It's not because they don't know how to use the healthcare system. Our patients are actually pretty smart. They know that in a community that lacks healthcare, the emergency department is one of the few places you can go to get quality healthcare. Number two, it looks like frequent admissions for ambulatory care sensitive, poorly managed conditions. So these are admissions for things like diabetic ketoacidosis, hyperglycemia, exacerbations of asthma and respiratory illness, high blood pressure, kidney failure. We see these conditions every single day in our hospital. This is what people are admitted to the hospital for here. There's an epidemic of diabetes in this community, and we see tons of patients with diabetes that is very poorly managed. Diabetic amputations and wound care are the most frequent surgical procedures we do at this hospital. Sepsis is the #1 inpatient diagnosis. These are all in stage complications of poorly managed illness that should be better managed in the community, but our patients don't have access to better management in the community. It looks like inadequate follow-up after hospital discharge, with patients coming back to the hospital for readmissions because, again, they're not getting appropriate care in the community. And it also looks like a high prevalence of comorbid medical and behavioral health conditions that go together and that need to be addressed together in order to improve the health of our patients. Next. So I thought we should talk a little bit about, what are some of the barriers to health equity. So first, I'm going to talk about the barriers that I think are, most relevant to us as providers, and that these are barriers to access and quality. And I'm going to start with the health insurance, the fact that many people in our community still lack health insurance, which I am hopeful that CalAIM is going to help address. But even with adding health insurance, that does not guarantee access. And we know that within the Medicaid program, Provider payments are very low relative to payments in Medicare and commercial insurance. And because of those low payments, particularly in communities of concentrated poverty, where there's high reliance on Medicaid, there's a lack of providers in those communities. Providers in our community can't do what Kaiser does. You know, Kaiser doesn't have that many Medicaid patients relative to their size, but my understanding is that they're losing $1 billion a year on their Medicaid patients. And the only reason they can do that is because they can subsidize those losses with more lucrative commercially insured patients. Well, our community doesn't have that many commercially insured patients. So providers in our community are reliant on low Medicaid rates, and they simply aren't adequate to provide high quality care in the community. Hospitals are lucky because we get supplemental payments, so we don't have to live off of Medicaid rates. But community providers, as you well know, do not. So I think this is a huge problem. It's really a problem of lack of access to community-based prevention and disease management. The providers in our community are underfunded. There is a mythology, I think, prevalent among policymakers that, you know, all patients in our community needs are primary care, allied health professionals, and federally qualified health centers. And while those are all valuable assets and important things to have in a health system, they cannot meet all of the health needs of our community. Our community, like every other community, needs the full scope of medical care, which includes primary care, specialty care, urgent care, pharmacies, etc. And, you know, I gave an example of this. You know, unfortunately, emergency departments should not be serving as a medical home. I meet with the medical director of our emergency department every couple of weeks, and he always has new stories to tell me about how he and his colleagues are basically serving as primary care physicians in our emergency department. One of his internal medicine buddies joked and said, you know, maybe you should brush up on your internal medicine. And he said, well, I'm an ER doc, I'm not an internist. But at our hospital, he's kind of functioning as an internist. And then lack of diversity and implicit bias among health professionals. We know that there is not an alignment between the cultural and ethnic background of our healthcare professionals and our patients. And there's been lots of evidence that minority patients get lower quality healthcare. And I fervently believe that we need to continue to diversify the health professions to help address that problem. Next slide. And then we've got the social barriers to health equity and the social determinants that we are very familiar with, including food insecurity, homelessness, lack of quality employment, transportation, poor quality education, and exposure to unsafe environments, whether those be toxins or lack of safe places to exercise, or in the case of COVID, being required to work at jobs that don't provide a safe environment. What I think we talk about less is a lack of political will to make the investments necessary to improve health equity. And I think that I've listed there some of the attitudinal barriers to that political will. I think often the inequities are invisible or not visible to the people who are making health policy and to the public at large. I think that we have an attitude that inequities are acceptable. So, you know, we're not motivated enough to make changes. I think we often feel that the investments we need to make are just too expensive. So, you know, how are we to fix these problems? And, you know, simply feeling that change is just too difficult, you know, that the problem is too big and we lack the wherewithal to address it. Next. This is what I would call my prescription, my personal prescription for advancing health equity. So I think first, we need to invest in infrastructure and payment for community-based care. Our low-income communities and our communities of color have ended up in this situation due to years of neglect. And many of these communities were created by redlining, housing covenants, discriminatory transportation policies, and they are now, islands of health inadequacy. And I think we need to invest in these communities, and then we need to pay appropriately for community-based care. We need to reduce variation in payment across payers. So this is what I call unequal healthcare, which is Medicaid paying significantly less than Medicare and commercial insurance for the same services. So why does that make any sense? And why is that not called out as, blatant structural discrimination and racism? That's what I think it is. We need to integrate medical and behavioral health care. If we don't address behavioral problems, we're not going to be successful in addressing our medical problems. A lot of them go together. We see a lot of patients at our hospital who have, for example, lung disease and heart disease because of substance use. We see people who have depression and it's interfering with their ability to manage a chronic illness. Trying to separate the mind from the body, it just doesn't work. We need to address the social determinants of health. And no, I don't believe that healthcare providers are responsible for all of the social determinants of health, but I think that we can do our part to address them, and we can partner with the social organizations and community organizations that are responsible for addressing them. And then lastly, we need to increase the diversity of the healthcare workforce. One of the structural barriers that people may not even be aware of is the fact that graduate medical education is financed largely through Medicare. So if you are a Medicaid heavy hospital, you actually get less funding for GME than hospitals located in more affluent communities that have a higher Medicare payer mix. So we recently started an internal medicine residency program at our hospital. Our support per resident is somewhere around $55,000 per resident, while a hospital in Long Beach or West LA is getting $185,000 per resident. And we all know that West LA doesn't need a bigger pipeline of physicians for West LA. So that is a structural inequity that also doesn't make sense. Next slide. And then I want to end the presentation part of this with a little bit about what we're doing as a health system to advance health equity. I think our number one priority is building a high quality integrated system of healthcare for South LA. We believe that people who live in our community deserve the same quality and the same access as people who live in more affluent communities. And we are determined to build the system that will provide that care for them. We also think it's really important to shed light on the consequences of health inequities and to basically tell our story about what this looks like. We talked about the fact that frequently the consequences of health inequities are invisible to policymakers. Well, we don't want it to be invisible anymore. We want people to know exactly what's happening in communities like ours. And that is why we made a decision during the COVID pandemic to allow media to embed in our hospital and to learn about what's going on in our community. We did that not because we wanted to report on COVID. We did it because we wanted to report on the underlying disparities in access and quality in our community. And we feel like it was pretty effective. We are very strongly advocating for equitable policies, for parity for Medicaid, for parity in graduate medical education training, for integrating behavioral health and medical health care, and for diversifying our workforce. And we are in the process also of training a more diverse workforce, nurses, doctors, and providing a pipeline from high school through graduate school, mentoring young people so that we get a more diverse workforce. And I think that is the last slide. So I am going to turn it over to you, Hector, for questions and discussion.
Wonderful. Well, let me just start off by thanking you again, Dr. Batchlor, for being that spokesperson, bringing a voice not only to South Los Angeles, but all communities that are really underserved and underfunded, underinvested. And we know that South LA is the epicenter of everything that ails California and ails the United States. And
either South LA or the Central Valley, right?
Yeah, so you're bringing us a really a great perspective. Dr. Robert Bitonte, who's one of our board members, wasn't able to join us tonight, but he practiced in South LA as a physical medicine and rehabilitation physician for many years, serving Medi-Cal patients. And his perspective is that what you're saying is we need to first invest in equal payment for the workforce and institutions working in these underserved areas, because that'll immediately not only reward those who are already there, but potentially attract others and make it sustainable. The second piece, he says, is we need infrastructure and technology and the other tools that we need to be more effective at delivering care in these underserved communities. And then, of course, third, the longer term vision is the workforce. Could you describe a little bit about what you've been doing in those three areas? Obviously, we'll talk a little bit more about the Medi-Cal payments, but just the areas of advocating for that, and then the infrastructure and the workforce.
Sure. So, we've been trying to build the infrastructure since 2010, which is when I signed on for this adventure. And even before the hospital opened in 2015, we were busy designing what we would call state-of-the-art technology. So we opened, as an all-digital hospital. We quickly became HIMSS level 7, which is the highest level of use of technology in a hospital, and it's been achieved by about 6.5% of hospitals, and we've maintained that over time. We've invested in an electronic health record system, which, I'm not going to claim I'm in love with electronic health record systems. I think they're all suboptimal, but at least we're using the technology that's available as best we can. And, creating the population health databases and tools that go with it to be able to measure our performance and then to target areas for improvement and to support our patients in managing their health. We also, quickly after opening the hospital, started to develop a medical group so that we could recruit and support physicians, high quality physicians, to come and practice in South LA. And we need those physicians both to provide high quality care at the hospital and to provide community-based care. Where we have the biggest challenge is on the community side because of the low reimbursements in the Medicaid program. As I mentioned earlier, on the hospital side, we get supplemental funding, which all safety net hospitals get, but it's in the community where we have the biggest challenge with resources. And we are advocating, really strongly in the legislature, both in Sacramento and in Washington, for better payment policies. I actually had a meeting last week with the head of the Medicaid program at HHS, at CMS. And I think that CMS and HHS in this current administration are very serious about doing something to address health disparities and inequities. They have to operate within their legislative authority, but within that authority, what I heard was thoughtfulness, creativity, and a serious commitment to making some policy changes that will help improve equity. So I do believe that our federal government is serious about it. And you know, if you don't know this already, the head of CMS is an African-American doctor, a woman who is quite committed to improving health equity. We're also doing the same thing in Sacramento, and talking to our policymakers there about what it looks, what healthcare in our community looks like, what health disparities in our community look like. We host those policymakers to visit and to, you know, see it for themselves, so to speak. And let me tell you, when they come to visit, it's an eye opener for them, because we don't mince words and we don't soft pedal, you know, what's actually happening in the community. You know, we talk about the dysfunctionality in the Medicaid program and in Medicaid managed care. We talk about the fact that our patients can't access their doctors, can't get specialty care. We talk about all of that. And the last time we had a group here, someone in the group said, "Oh, that's against the Medi-Cal rules." And all of our doctors laughed and said, "Well, it may be against the rules, but this is how it works." I think the other thing you asked about is training. And, you know, we're really doing a lot to support training as well. We train nurses who are new nursing graduates. So we train the nurses who are right out of nursing school. We also train experienced nurses who would like to practice in a different specialty area. We have pipeline programs for both graduate students, college students, and we just started a program this summer for high school students who are interested in careers in healthcare, not just medicine, but in any area of healthcare. And we also are hosting a couple of graduate medical education programs at the hospital, with internal medicine just starting this year, having matched 5 new young doctors in an internal medicine residency program. So I don't know, did that cover all those areas?
Yeah,
Hector?
she sure did.
Mhm.
And congratulations on your residency program. It's high time that the contributions that Martin Luther King Hospital itself has made in its previous iteration to the community gets recognized and expanded again. So thank you.
Thanks. And you know, one other thing I would say is that, you know, particularly during the COVID pandemic, like everyone else, we really ramped up our telemedicine capabilities. And, you know, we put a chat bot on our website that educates and triages and connects people to care. We contracted with a telemedicine company so that even patients who don't have an insurance plan or IPA connection to telemedicine would have that telemedicine available to them. We really ramped up virtual care and did, you know, paramedicine, home visits and whatnot. So, you know, we're really trying to leverage telehealth as well. But I have to issue a cautionary note about that. What I worry about is I worry about turning telemedicine into another, you know, third tier of access and quality for underserved communities. You know, we are now starting to see patients who haven't been able to have an in-person meeting with a provider in over 2 years. And not everything can be done through telemedicine. The other concern I have is about hospital at home. I think hospital at home can be a great advantage, but I think if you're talking about low-income communities who don't have people sitting at home waiting to take care of a sick person, it can become another burden on the family. Yep. And it may, you know, be great for a payer and for a hospital to get people out of their hospital faster, but they're really transferring that person's care to a family. And not every family has people sitting at home waiting to take care of a sick person. So I think we have to be very careful about how we use these new approaches and new technologies, and don't turn them into another, you know, lower level of care for our communities.
That's a great point. It's, you know, there's tools, and the tool is only as good as how they're used. Yeah.
Yep.
I want to invite the audience to put their questions in the chat. We did have some questions that were submitted through registration, but I want to give Dr. Omer Deen a chance to ask a question, which kind of piggybacks on the augmentation of Medi-Cal payments. So Dr. Deen.
Thank you. Appreciate that. Thank you again, Dr. Batchlor. Fantastic presentation. I just wanted to get your personal thoughts. We often discuss within the organization ways that we can advocate for higher and equitable rates, reimbursement rates, especially in this case, Medi-Cal, Medicaid rates. What are some thoughts that you have of approaches that might be successful in getting those rates at least up to par with Medicare rates?
Well, I really believe that the most powerful motivator for change is visibility. That we really have to make the disparities and the consequences of these disparities visible, emotionally compelling. I was reading something today. There were comments from a Harvard School of Public Health professional who is an expert in health disparities. And he said something that I thought was really profound. He said that, we've really grown to accept the existence of these health disparities because we don't feel emotionally connected to them. And stories are powerfully connecting, which is, why I think that working with the media to tell stories about people and the impact that lack of access to healthcare has on their lives and their health. So I really think that we need to make it much more visible. One of the projects that Hector and I and some other folks have been working on recently is a research project to compare the rates of admissions to hospitals for ambulatory care sensitive conditions across the county and across the state, because that is another way of highlighting the lack of access to quality care in the community. So I think we have to just keep telling the stories, keep making the problem visible, and then, push our elected officials and policymakers to solve the problem. And I don't think we should accept a lot of lame excuses for why we quote unquote can't do it. If we can fund prisons, we ought to be able to fund healthcare.
Absolutely. The evidence drives the policy change, but it's the stories that put a face to those.
Yep.
Issues.
So it's a combination of data, stories, and holding people accountable.
Absolutely. And again, just a reminder to our attendees, if they can put their questions in the chat, we'll be able to kind of group them together. A follow-up to Dr. Deen's question is the other coalition that we're working with, to try to get attention to at the state level for enhanced Medi-Cal payments. And I'm curious whether that came up in your discussion with Dr. Brooks LaSure, this Medicaid director, whether they would support, the state in doing that.
Hector. So when I talk to people like Chiquita Brooks LaSure and Daniel Tsai, who's the Medicaid director working under Chiquita, they're very careful to preface their comments by saying, we are going to do what we can within our legislative authority, because they work within a legislative framework. And Dan was pretty straightforward with me the other day, and he said, we can't tell states straight out what to pay providers. But there are other things that we can do, like using the 1115 waiver program to push for things. So I think the problem for CMS is that, their view is that they really cannot just come out and tell states, you must pay providers X. But they're looking at other ways of getting to the same place.
Mm-hmm. And it's really imperative because there's so many pieces to the Medicaid program or Medi-Cal. It's the payment for the sustaining payment for providers, hospitals, doctors. but also the GME port, as you mentioned it.
Yep.
And we need to bring that to the table here in California.
Mhm.
And then long term, it's, the general investment that brings to a community, which is all those social determinants that you talked about. And, you have a colleague at Harvard, Dr. Jose Figueroa, who also is writing a lot about persistent low Medicaid payments are part of that infrastructural and
Oh,
structural
good.
racism. So,
Good.
we're getting at it from both coasts, I think, which
Yeah,
is
I'm
great.
starting to see this issue of low payments getting more traction.
Mhm.
And I think we have to keep talking about it. It's a little bit of a complicated issue because Medicaid varies from state to state. And there are some states where Medicaid providers actually get paid more than Medicare pays.
Yeah.
Not very many, but there are a few.
Yeah.
So it's a little more complicated than just saying, Medicaid is terrible everywhere. But in general, Medicaid is paying half of what Medicare pays providers. So we need to keep pushing on this issue, especially while people are interested in the topic of health equity.
And a follow-up question from our guests is what do you think, or what is maybe your thought about the Healthy California for All Commission report on trying to unify all the forms of payment? Do you think that would enhance the strategy for Medicaid enhancement?
Yes.
Or would
Yes.
it distract?
Yes. I think it would. I mean, I think, a good example is Maryland, which is the only state that I know about that has a all-payer rate setting program for hospitals. So hospitals in Maryland get paid the same rates by every payer, whether it's Medicaid, Medicare, or commercial insurance. I think, it would raise the bar for Medicaid. It'll probably lower the bar for commercial.
And I understand that Carmela Coyle, who now is the CEO of the California Hospital Association, was involved in a lot of that planning in Maryland in one of her previous hats.
She was, but let's be honest, hospitals are not in favor of rate setting. And, and California is approaching that. So there was a bill that was passed that is going to set up something called the Office of Healthcare Affordability in California. And the goal of that Office of Healthcare Affordability is to constrain the growth of healthcare costs in the state.
Mhm.
So this is the first step toward rate setting in California.
Yeah.
And hospitals are not excited about it.
Well, because it exposes some of the issues that they've, been sort of benefiting from
Yep.
historically. And
Well, most hospitals' position is that they can't live off of Medicare rates.
Mhm.
That if they had to live off of Medicare, they would go belly up.
and we know they're all marketing to Medicare right at the same time. So it's and actually there were a couple questions in the chat related to Medicare that it's also falling behind in providing adequate payment. I think this is something Dr. Deen has highlighted in the past, that other than the cost of living increases, it has not kept pace with inflation and everything, the cost of running a hospital, running a practice. All the more reason that we need to kind of get our arms around, the funding and being able to unify that.
Yeah, I hate to tell you, I just came from a hospital association meeting. So, if you want to know what are you expecting from Medicare rates, what I heard is we should expect rate cuts.
Mm.
And
Yeah,
I think that, this is going to be a challenge for everyone because our population is aging. And so, people are aging out of commercial insurance and into Medicare. And, providers are going to be squeezed.
Yes, absolutely. And, one of the issues that came out in the HCFA report, the Health California for All Commission report, but hasn't received a lot of attention is that employers are bearing a lot of those cost shifting, right?
Yep.
Hospitals
A
say,
thin slice of commercial insurance
yeah,
is holding up a lot of subsidies.
yeah, and I've seen reports that hospitals can negotiate anywhere from 150 to 200% of Medicare rates for commercial, and if they're important enough in the marketing that the health plan has, they're willing to give them that amount. but it also discombobulates fairness everywhere else, right? And so
Yep,
one of the
yep.
issues that I think,
And employers are getting a little tired of subsidizing the whole system.
yeah, and yet they like the control of having their own health, insurance benefit, as especially the multi-states, which then hide behind the ERISA. There's a couple other questions in the chat about social determinants and social barriers. What do you see is the ideal solution to what right now become as disparate funding streams? There's the healthcare model, the traditional, and then there are the social drivers. As you mentioned, CalAIM has a lot of promise in showing us how to do it better. What about other investments we make as a society? How should those be enveloped together with the delivery system? Or
Well,
should
I think that we need to think in terms of integration, just like we need to think in terms of medical and behavioral health integration. We need to think of broadening our view as we're providing healthcare to include connecting people with the benefits and the organizations that are responsible for those social determinants of health. And I can give you some examples of what we do at our health system. We have a large homeless population that we care for here. We recently made a deal with a homeless housing provider, a provider of shelters, homeless shelters. They developed a new shelter with 60 beds, and we agreed to pay for all 60 beds so that we could refer our homeless patients to this particular shelter. Now, fortunately, CalAIM includes funding for homeless services. So hopefully this will not all be on our dime, but I think it's a good example of that type of partnership.
The more I hear you speak, the more I realize you're creating a revolutionary transformation in South LA. And God bless you. We need more exposure to what you're doing, because obviously resources would make it happen that much.
Well, I don't know whether you know Dr. Jorge Reno. He's our Senior VP for Population Health. That particular collaboration was his baby.
Fantastic. Well, it's working, and we look forward to hearing more in the future. Another question in the chat is finding the political will. I was at an ACO Congress back in 2012 when they were being accountable care organizations were being expanded through the Medicare shared savings program. And Don Crane, who was leading the California Association of Physician Groups, was one of the speakers, and he said, if we're not careful, ACO will go from accountable care organizations to advancing cartel opportunities, right? And so much of healthcare is driven by special interests.
Yeah.
Where can the political will be found when they're being pummeled by lobbyists and other special interests? How do you see
I think that as doctors, we are in a unique position to talk about the human impact of policy and to advocate for doing the right thing, and calling people to task and accountable for doing the right thing. The other thing I would say is that we all need to vote and be part of civic engagement. I'll tell you that my husband is a public defender, and he takes off a month every year to go to a swing state and help whatever campaign he can in that swing state. I've raised 2 boys, and one of my sons teaches civics to 5th graders. He's a junior in college. He's an active member of the Democratic Club at his college. He campaigned for the new mayor of Boston. We need to be engaged in the political process in the right way, and not just knee-jerking it and only doing things that protect our cartel. We need to be engaged and supporting elected officials who are going to do the right thing as far as health disparities and equity are concerned.
Very well said, and that is part of the community engagement, is the building power and
Yep,
a lot of the work
yep. I think I spend the majority of my time now on policy advocacy, going to Sacramento, talking to elected officials. So just last week, I was part of a group that met with the president pro tem of the state Senate. This is actually time well spent, I think.
Yeah, absolutely. The other piece is, you come from a family that's been activists and, mobilizing community. You shared that earlier in your bio, it's reflected. You also shared a really important story with the LA Times about your mother not wanting to get the vaccine. And here's a woman who's very powerful in her own right, a community organizer, an activist. Can you share a little bit of what you learned through that experience? I thought it was a really moving story that you shared.
Oh, thank you, Hector. Well, as you can imagine, I lived with my mother my whole life, so I knew her pretty well. And she was a very smart, I always tell people she was smarter than me. She went to college when she was 16 years old. She went to Reed College in Portland. And she was smart, she was tough, and she was a really strategic thinker. But I have to say that at a certain point, she also had personal experiences in the healthcare system and in life that made her distrustful of healthcare and of, institutions in general. And I didn't even write in that article what she actually said. So when the vaccines became available, my mother looks at me and she says, well, Black people are no fools. We know that the vaccine they're going to give themselves is not going to be the same vaccine that they give us. That's what she said. And this is a woman who watches CNN all day. So she was very well informed, probably too well informed, like every time there was some report about someone who had a, side effect, she would talk about that. Very well informed. And she, to her dying day, refused to get vaccinated. Amazing.
But it shows the power of that structural racism we talked about and how it impacts us in different ways.
Yep.
And that story is so powerful. And I appreciated that you shared it with the public.
Yeah, and she lived with our family for many years, and everyone else in the family was fully vaccinated. It used to drive my husband crazy that she wouldn't get vaccinated.
No, very true. Very true. Well, Dr. Batchlor, I want to thank you for a wonderful discussion and presentation, and really your vision there. I truly believe that you're just creating a radical transformation of healthcare and showing the rest of the world how to do it.
And thank you, Hector. And I also want to say that it's been a complete pleasure to work with you on, advancing health equity, because you're equally smart, strategic, and you've been in this fight just as long as I have. So I really appreciate having you as a partner in this work. And I, welcome all of our physicians as partners as well. This is our life's work, and I think it's important.
So thank you very much again. Dr. Deen, any parting words as we wrap up our program today?
I'd like to echo what Dr. Flores said. Thank you so much, Elaine, for being here with us and for your knowledge. We'd like to keep this line of communication going and collaborate with you as LACMA to see what we can do for our community here locally.
Thank you, Dr. Deen, and thank you to all of your members who participated tonight. Really appreciate your interest.
Thank you again. And just a reminder to our participants, you'll be getting a link to evaluation for the CME credit. So again, thank you, everybody. Appreciate it very much.
Good night.
Have a good night.